Hello, welcome back to Perspectiva. Now, a new study is raising concerns that current breast cancer screening guidelines may be leaving thousands of women at risk without early detection. Well, researchers say that the existing National Health Service criteria for women under the age of 50 relies heavily on family history and inherited genetic factors. However, the study suggests that this approach fails to identify the vast majority of women who may later develop breast cancer because many have no known family history of the disease. Well, breast cancer remains one of the most common cancers affecting women and is the leading cause of cancer-related deaths among women under 50 in the UK. While routine breast screening is offered from the age of 50, younger women are genuinely not eligible unless they are considered to be high genetic risk. Now, the research highlights that risk factors extend beyond inherited genes and include lifestyle, reproductive history, hormonal factors and other health information. Now, experts believe that combining these factors into a broader risk assessment could help identify significantly more women who would benefit from closer monitoring and early intervention. Now, the findings have renewed debate over whether breast cancer screening should move towards a more personalised approach, allowing healthcare providers to assess each woman's overall risk level rather than relying primarily on family history. There's details in this report.
Breast cancer affects thousands of women every year, yet identifying those at greatest risk before symptoms appear remains a significant challenge. According to the latest research, the current screening approach for women under 50 may overlook many individuals who are more likely to develop the disease because it focuses mainly on inherited risk. Researchers evaluated a multifactorial risk assessment tool that considers family history alongside other important factors such as lifestyle, reproductive history, and genetic information. They found that the model identified substantially more women at increased risk compared with the existing referral criteria. The study estimates that more than 1 in 4 women under 50 could be identified as having an above-average risk through this broader assessment. More importantly, the tool could detect a much larger proportion of women who may develop breast cancer within the following decade. Health experts say earlier identification could allow women to receive additional monitoring, preventive advice, and timely medical assessment before the disease reaches an advanced stage. At the same time, specialists acknowledge that expanding risk assessments would present challenges. Referring more women for further testing could increase demands on healthcare services and may also lead to unnecessary investigations, anxiety, and false positive results. Current national screening programs in the UK are designed to balance the benefits of detecting cancer early with the potential risks associated with overdiagnosis and unnecessary treatment. Health authorities say they welcome ongoing research into improved methods of assessing breast cancer risk, but maintain that more evidence is needed before national screening guidelines are changed. Medical experts continue to encourage women of all ages to remain aware of any changes in their breasts, including new lumps, changes in size or shape, skin dimpling, nipple discharge, or persistent pain, and to seek medical advice promptly if any symptoms are noticed. Early diagnosis remains one of the most effective ways to improve treatment outcomes and survival.
Well, the study adds to growing international discussions about whether breast cancer screening could become more personalised by considering a wider range of risk factors rather than focusing primarily on family history. While researchers believe that broader risk assessments could improve early detection for many women, health authorities stress that any changes to screening programs must be carefully evaluated to ensure they're effective, equitable and supported by sufficient healthcare researchers. For now, routine breast screening in the UK continues to begin at the age of 50 for most women, with earlier screening available only for those who meet specific high-risk criteria. Now, medical professionals do continue to emphasise that screening is only one part of the breast cancer prevention and early detection. Understanding personal risk factors, maintaining a healthy lifestyle, attending recommended health appointments and reporting any unusual breast changes without delay all play an important role. Now, as research continues, experts hope that the future advances in risk assessments will help identify more women who could benefit from earlier monitoring, while ensuring that healthcare systems remain both effective and sustainable. To discuss this alarming situation, we're joined by Dr. Omer Awan, who is a physician and a senior health contributor for Forbes. Sir, hello and welcome to Perspectiva. So the new study suggests that the current NHS screening criteria could be missing a large proportion of women under 50 who are at higher risk of developing breast cancer. What do these findings tell us about the limitations of the existing screening system?
Well, the current screening system in the UK really focuses on a couple risk factors, and that is age, family history, and genetics. But it doesn't take into account many of the other important risk factors for breast cancer, particularly lifestyle factors, things like alcohol, obesity, physical inactivities, even hormone replacement therapy. All these are significant risk factors for breast cancer, and that's probably why many cases are being missed, particularly in younger individuals and those that are under 50 years of age. And that's what we're seeing. That's why a lot of high risk women who are under 50 are developing breast cancer because some of these could be missed because these risk factors aren't being accounted for in the current risk paradigm.
So researchers argue that relying mainly on family histories is no longer enough to identify women at risk. How important is it to include factors like lifestyle, reproductive history and genetics when assessing an individual's breast cancer risk?
It's very important because we likely are going to be missing a lot of breast cancer in younger individuals, younger females, particularly those that are under 50 years of age. So about 20% of breast cancer diagnoses occur in patients and females that are under 50 years of age. That's 1/5 of individuals. And if we only rely on factors like family history or genetics, which is very important because age is an important and maybe the most important risk factor for breast cancer. The vast majority of breast cancers do occur as you age, but we miss all of those that are, related to obesity or related to physical inactivity, lifestyle factors that are becoming more and more important as, obesity rises globally, physical inactivity, lack of exercise. All these things have alcohol use, for example. All these things have a major effect, and we start to miss those breast cancer diagnoses, essentially. And importantly, one statistic that I think is very telling is that of those that are diagnosed with breast cancer under 50 years of age, about 75% of them don't have a family history. And the vast majority of the UK screening protocol is really about family history and age. So certainly very telling about how we should change the paradigm for breast cancer screening and why there's such a stark disparity between the amount of people that are being diagnosed and potentially so many high risk females that are not potentially being identified for breast cancer diagnosis.
Well, the study found that many younger women who develop breast cancer have no known family history of the disease. Why is breast cancer becoming increasingly difficult to predict using traditional risk factors alone?
Yeah, it's becoming very difficult. And part of that is because some of these risk factors aren't being identified very early on. Again, if we only rely on, age, genetics, which is, the BRCA1 and the BRCA2 mutation, those are the two genetic predominant risk factors that we look at, that having those genes significantly increases your risk for breast cancer. Relying on age, relying on family history, again, all very important, but then that doesn't tell the whole picture, right? That doesn't tell the whole picture with respect to who is very high at risk for breast cancer, and particularly in younger individuals. Many younger individuals who end up having breast cancer don't have those risk factors. Again, nearly 3/4 of women diagnosed under the age of 50 with breast cancer will not have a positive family history for breast cancer. And, the genetic mutations, the BRCA1 and the BRCA2, that's overall rare. I mean, most women who are young won't have that gene mutation. So the vast majority of women who are going to be diagnosed with breast cancer are going to have, potentially increased alcohol use as a risk factor, or, physical inactivity, obesity, hormone replacement, or, oral contraceptive use. Some may have no risk factors. And that's another important point that we have to consider when we talk about breast cancer and breast cancer risk. Some women come in and have no risk factors for breast cancer, but then still develop breast cancer. So, this is why a holistic approach is important, and, reevaluating our criteria for who to screen from time to time is also important by doing more research, by doing high level research to identify, well, what is the sweet spot? What area can we really do screening where we're maximizing the benefit and decreasing the harm? I think that's going to be an important point, and potentially even personalizing and doing precision screening where we, look at people's individual risk factors and identify, well, who is most at risk and should we screen them? These are all questions that a lot of researchers, a lot of public health officials, we're going to have to wrestle with as we determine what the most optimal way and strategy is to screen women globally for breast cancer.
Well, if broader risk assessment tools were introduced into routine healthcare, how could they improve early detection and treatment outcomes for women under the age of 50?
Well, if there's broader risk assessment, that means more people will be screened, right? So we're not only relying on age, we're not only relying on genetics, we're not only relying on family history, we're relying on a plethora of risk factors. So the broader it gets, the more people can be screened. And, it's important to note also that some countries do it differently. So for example, in the United States, screening actually starts at the age of 40, not at the age of 50. And we screen every 2 years, not every 3 years. So in the UK, screening starts at the age of 50 and is screened. Women are screened every 3 years until the age of 71. In the United States, for example, women start to get screened for breast cancer with a mammogram at the age of 40, and it occurs every 2 years till the age of 74. So it starts earlier and it goes later. And that potentially has identified more women who could have a positive breast cancer diagnosis. So the broader we get with screening, the more likely it is that we're able to find and detect more women who have breast cancer. And that is life-saving. We know that screening saves lives, and screening, research has shown in the United States that screening starting at the age of 40 yearly can decrease mortality by 40%. And that's an important figure because the screening works. And when we screen people, we're able to find and detect breast cancer even before symptoms start, and it saves lives. So that's an important point for viewers to understand.
Well, expanding breast cancer risk assessments could lead to more women being referred for additional screening and testing. How could healthcare systems balance the benefits of earlier diagnosis with the risks of overdiagnosis, false positives, and increased pressure on medical services?
And that's the sweet spot. And that's really what screening is all about, trying to balance the benefits and the risks. We want to develop programs where we maximize benefit but decrease risk. And there are risks associated with screening, and that, anytime you want to change the screening program or the screening protocol, if you want to make it earlier, if you want to increase and broaden screening programs, there's always a risk. And in breast cancer, that would be, one is false positives. And that is, having a positive test when in fact a breast cancer diagnosis doesn't exist. And that's a false positive. And the more as you screen earlier and at younger ages, you're going to have more false positives. And that's a problem because that can also lead to anxiety. You can imagine that a woman may feel a lot of anxiety if she gets a diagnosis of breast cancer, but then in fact it's not real, right? So that can be very anxious for individuals. It can also lead to overdiagnosis. And that means that we identify breast cancers that wouldn't be clinically significant. They wouldn't have harmed the patient. And that's also a problem because if you diagnose it, that it can result in a lot of resources, a lot of cost for the healthcare systems for a patient when in fact it wouldn't have been needed because it wouldn't have been relevant significantly. It wouldn't have even caused symptoms, and it may do more harm than good. And then of course, when you have a positive diagnosis of breast cancer, that can lead to further testing, further biopsies, and that can harm a patient, right? Because every intervention has risks. Anytime you do a biopsy, there's always a risk of infection. There's always a risk of bleeding, injury to other structures around your body. All those things can be harmful. So that's why it's always about identifying the sweet spot between what's the benefit and what's the harm, and how can we maximize that benefit and minimize the amount of harm for breast cancer diagnosis. That's really what we're looking at. That's what public health officials are trying to do when they develop these screening protocols. And that's why public health officials are always hesitant to change them and, bring down the breast screening age from 50 to 40. Well, they have to assess and look at research to identify, well, what exactly is the benefit to risk ratio and how can we optimize that?
Well, routine breast screening in the UK genuinely begins at the age of 50. Based on current evidence, do you believe that screening guidelines should be reviewed for younger women? And what factors should policymakers include before making such changes?
Well, they definitely should review it, particularly in light of this research when, 95% of women who are high risk may be missed who are under the age of 50. That's a significant number. That's a significant number of people who may be missed for the utility and effectiveness for breast cancer screening. So definitely something to look at. More research needs to be done to evaluate whether or not this will make a difference from a mortality standpoint, from saving lives. I believe it probably will. And, other countries, Canada, Australia, I think even Sweden, United States for sure, screen at a much earlier age. The United States, changed from 50 to 40 in 2023 based on the United States Preventive Services Task Force guidelines, and now we screen every 2 years starting at the age of 40. Perhaps there's a opportunity for the UK to do that as well in light of this research. Certainly it needs to be evaluated to maximize the benefit of screening programs. Age is one factor, and I think that's an important factor. But ultimately, in the future, there may be more precision screening where we identify people not just based on age, but based on risk. The question won't be, what is your age? The question will be, what is your personal risk for developing breast cancer? And that's going to be dependent on not only age, not only your genetics, not only your family history, but also your personalized risk factors like alcohol, obesity, your surgical history of chest radiation, whether you took oral contraceptive pills. All these things will be critical in identifying one's risk going forward.
Well, beyond screening programs, what steps can women under 50 actually take to better understand their own breast cancer risk, like recognizing early warning signs and seeking medical advice at the right time?
Well, one is just like knowing your risk, knowing, what your age is, knowing your genetics, perhaps do you have a genetic mutation that like a BRCA1 or a BRCA2 that can predispose you to having breast cancer? Many women don't know if they have family history is positive. Knowing, making sure that do you have a mother or father that has breast cancer? Do you have an aunt, a maternal aunt that had breast cancer? All these questions are very important. And, unfortunately, not every women know the answer to those questions. Also, maintaining a healthy weight is very important, right? You don't want to obesity can increase the risk for breast cancer. Being physically active, much research shows that the more active you are, the less likely you are to develop not only breast cancer, but many other cancers. Limiting alcohol intake. Alcohol is directly associated with the development of breast cancer. So, knowing your risks and modifying your risk factors is very important. The other is knowing and understanding the signs and symptoms of breast cancer. So, for example, also understanding that there can be no symptoms with breast cancer. So that's why, again, it's important to get screened at the appropriate times. But also, if you develop a new lump in your breast, or if you have a lump and that size has changed, that's an indication you may have breast cancer. If you develop lymph nodes or lumps under your armpit, that's a sign that you may have breast cancer. If you have noticed redness or pain in your breast, if you have scaling in the skin of your breast, if you have nipple discharge, particularly if it's bloody, that can be a sign of breast cancer. If you have inversion of your nipple, that can be a sign of breast cancer. So weight loss, significant weight loss can be a sign for breast cancer. So all these are important signs and symptoms for breast cancer that you shouldn't, you should take precaution. You should take them seriously. And certainly you should not all of them will end up being breast cancer, but it's a reason for you to get evaluated by your doctor on whether or not you may have breast cancer. So that's important. And then also what I would say is just talk to your doctor. Have a conversation with your physician about your risk, about whether or not you should get screened. Do you qualify to get genetic testing? Should you get screened earlier based on, the risk factors that you have? That conversation is also important for women to understand going forward.
And so, looking ahead, how do you see advances in personalised medicine, genetic research and AI transforming the way that breast cancer risk is assessed and managed in the future?
Well, I think it will have a profound effect, and that's going to be the future for, breast cancer and breast cancer screening. So definitely precision medicine will again be, what is your personal risk? It won't just rely on age and some, genetic factors or family history factors. It will be tailored to everyone individually. Different people will have different risks based on their own risk factors. Some people may have a higher risk because they drink more alcohol or because they're overweight. All these things will be different based on one's own personalized risk factors. The age and that number doesn't tell the whole story. And I think by being more personalized and having a more personal approach, that can change the way screening is done in the future. And artificial intelligence will also have a major role, and it already is. We use artificial intelligence in helping us diagnose and interpret mammograms for breast cancer. Radiologists, physicians always use that already for their interpretation. I'm a radiologist myself, and I can tell you that we use artificial intelligence on a daily basis to help us diagnose breast cancers on mammograms. Another important thing is that artificial intelligence helps us predict one's risk, right? It can, just like we're talking about, predicting risk factors, artificial intelligence algorithms and machine learning algorithms can help in predicting one's risk for breast cancer. And that's also very important. But also important to understand that AI is a tool. It's not an all ends, and it's not, the final solution. It's a tool that radiologists use to help them and to make them more efficient, but it certainly needs physician oversight. AI needs to be regulated by physicians so that it can be used effectively and so that it doesn't do harm, and so that there's not a lot of bias when it's used. That's also an important point. So that's really how the future will go. It will, rely likely more on precision medicine, precision screening that's more tailored to the individual, in conjunction with AI, where hopefully AI will help us. It'll augment the way we do practice, the way we're able to diagnose, the way we'll be able to stratify risk factors, but it will require a lot of physician oversight going forward. So, definitely very exciting times for medicine, very exciting times for screening protocols, and hopefully this will ultimately lead to better and more effective patient care.
Perfect. Thank you so much. Really appreciate it. Well, that is all for today's edition of Perspectiva. Our thanks go to our guests for sharing their views on the EU's call for stronger border security following the recent migrant crossings into the Spanish city of Ceuta, and for shedding light on the rising breast cancer risks in women under 50. Please, for more stories and updates, follow us on social media or visit Asiaone News TV. Thanks for watching. I'm Tom Philpot, and we'll see you next time.